Thank you very much, Kevin, and Daria. It's an honor to be here, and I'm so happy to be part of the SPARK program. I would like to share with you our experience with repurposing a drug, FK506, for the treatment of pulmonary hypertension, and SPARK essentially funded a clinical trial that we did. So I just want to introduce first our team. I'm a clinical scientist interested in pulmonary hypertension. I also see patients with pulmonary hypertension. And I'm interested in really repurposing drugs to treat the disease and really reverse vascular remodeling. My partner is Roham Zamanian, who is the director here of the adult pulmonary hypertension program, and whose clinical focus is trial design, biomarkers, imaging, and this is kind of a very good partnership to take our research to patients. And then my research assistant who did biomarker work, and then of course our adult pulmonary hypertension clinic with our trial coordinators. To give you some scientific background, pulmonary arterial hypertension is characterized by progressive narrowing of the pulmonary arteries, leading to first medial hypertrophy and then neointima formation. And ultimately, the right heart tries to adapt to this high pulmonary vascular resistance, but in many cases fails, which then leads to the high mortality that we see in pulmonary hypertension. On the left side, you see a normal pulmonary angiogram of the nice, abundant vessels in the lung, whereas on the right side, you see an angiogram of a patient with pulmonary arterial hypertension where you have loss of vessels and progressive obliteration. Untreated, the survival of this disease is very poor, just 2 to 3 years. We currently don't have a cure. We have medications that prolong survivals, the vasodilators, but they really don't cure the disease. And eventually, either patients succumb to the disease or a few patients are eligible for a lung transplantation. While the etiology is very diverse, we have a familiar form of pulmonary hypertension, but it's also associated with certain autoimmune diseases, with liver disease, with congenital heart disease. It's interesting that the lung pathology is similar. It's not the same in all cases, and in some cases there are more inflammatory cells around, but we are proposing in a way that there might be a very common pathogenic mechanism behind the disease. As I mentioned, the current treatment with vasodilators is not disease modifying, and you can see when you look at the histology here that when vessels are so much occluded, pulmonary vasodilators can only dilate vessels that are not so severely affected, but essentially we need a drug that can really reverse the remodeling in the vessels. And we were focusing on the genetics of pulmonary hypertension as a potential clue to what's driving this disease. So in familiar forms of pulmonary hypertension, about 80% of patients have a mutation in this bone morphogenic protein receptor 2. And what we've also found over the years now is that other patients who don't have a mutation often have a downregulation of this pathway. And many studies, many basic research studies have essentially shown that low BMPR2 signaling can mimic all different aspects of the histology of pulmonary hypertension. So we performed, and this was during my postdoctoral research in Dr. Abinovich's lab here at Stanford, we performed a high throughput screen of over 3,600 FDA-approved drugs to see whether there's any drug out there that could increase BMPR2 signaling. And to our surprise, we found that the immunosuppressive drug, FK506, tacrolimus, that is in clinical use over 20 years, was our top candidate. We then used this drug in different models, in different animal models of pulmonary hypertension, and one model mimics the clinical disease very well in that it's caused by an endothelial cell injury, and then animals are exposed to hypoxia and then are reoxygenated for a couple of weeks. And these rats develop severe pulmonary hypertension, as seen here, with an increased right ventricular systolic pressure and increased right ventricular hypertrophy, as measured by the weight of the right ventricle divided by the left ventricle and septum. And they also developed severe occlusions of the small vessels. And when we treated those animals at the time when they had established disease for 3 weeks with FK506, we had a marked reduction in the pressure, marked reduction in right ventricular hypertrophy, and an opening of the previously occluded vessels. We used a very low dose of FK506, as we had previously shown in our cell culture experiments that even low dose FK506 can increase BMP signaling. So this was kind of advantageous for us also then to move this into the clinic, because our patient population is different than transplant patients. Many patients are on intravenous prostacyclin, have an indwelling catheter, and so are very prone to infection. So to have a low dose of an established immunosuppressive agent, and we used the dose just with blood levels 1.5 to 2.5 nanogram, was ideal in a way to have a safe drug in this patient population. So we first used this drug in 3 end-stage patients with pulmonary hypertension who work in New York Heart Functional Class 3 and 4, who were on all available pulmonary hypertension medications, including intravenous prostacyclin. And one patient was even on additionally intravenous dopamine because she was so hypotensive that she otherwise couldn't be discharged from the hospital. All patients had frequent hospitalizations due to heart failure, with hypotension, with ascites, and 2 were scheduled already or were on the transplant list, and 1 was even too sick to receive a double lung transplantation. All patients had low levels of BMPR2 in their blood, but none of them had a mutation in BMPR2. And we treated those patients for over a year. And what we found was that in all patients, their 6-minute walk distance, which is a measure for functional activity, increased over this time frame of 90 meters. They had reduced heart failure markers as measured by NT-proBNP. It's a blood biomarker. And none of the patients had any hospital admission for heart failure. So this was really encouraging. We then wanted to make sure that while giving them FK506, we knew it's a drug that has many different effects. We're actually targeting the BMP pathway. We measured BMPR2 expression in PBMCs, peripheral blood mononuclear cells, and compared them to the normal levels of healthy controls. And what we found was that all patients had low levels to start with and increased their BMPR2 levels over time. We had 1 patient who started with like low normal levels. She also increased her levels, and she stopped FK506 after 4 months. And it was very interesting for us to see that she was readmitted after 11 months with severe heart failure. And at that time, her BMPR2 levels were very low. She was restarted on FK506 and is doing fine now. She's still not transplanted, and this has been now over 4 years. So then with this, we initiated a phase 2A safety tolerability trial. And this was necessary given that, yes, it is an FDA-approved drug, but it has not been used in this patient population. And our patients, as I mentioned, they have indwelling catheters, they have renal failure, they have liver failure because of their hypertension. So we initiated this trial. It's a 16-week trial with a placebo group and then 3 different groups of patients who receive FK506 at a low dose. The normal immunosuppressive range is 5 to 15, so we always try to stay below that. We couldn't go so much lower because there's no approved level test available at the very low dose, because currently it's only approved as a treatment for immunosuppression. We also collected biomarkers to see whether we can somehow develop a BMPR2 signature and whether we can identify patients that might benefit most from this therapy. We included 23 patients. This was generally a less sicker population, more in functional class 2, because we wanted to include stable patients. We had also a few in class 3. Generally, the drug was well tolerated. We completed the study in 2014, and we identified some BMPR2 responders, although our study with this small patient group was not powered for efficacy. What we found was we had some patients who increased their 6-minute walk distance significantly, like over 40 meters, some that decreased their heart failure marker NT-proBNP significant, and with echo increased the right ventricular fractional area change, their right ventricular function significantly. And in all those patients, these were the patients that had the most increase in their BMPR2 levels when compared from baseline to the 16-week follow-up. How did SPARK help in this project? They provided seed funding in addition to the Wall Center for Pulmonary Vascular Disease here at Stanford, so we only have, in a way, small seed funding for these trials. They introduced us to OTL, to different small companies. They taught us about different FDA regulations, IND, patent protection, and also helped us with trial planning with some expert SPARK advisors in the clinical trial design. And up until now, they really continue to support us to secure funding for a phase 2A efficacy trial, which is very difficult, and it's different from my speaker before, because FK506 is a generic drug, it's inexpensive. If we could show that it's efficacious in pulmonary hypertension, there's probably not so much money people can make with this, but it might be really a very important drug for the field of pulmonary hypertension. We have paired with a small company, Zelton Pharma. They're a small startup company focusing on developing treatment for rare diseases. They recently bought the patent rights for FK506 in pulmonary hypertension, but they're also still trying to secure more funding. And FK506 received an orphan drug status in 2015, and already there's an international patent secured in South Africa, and the others are still pending. And just an outlook into the future, so our research, in a way, sparked another researcher here at Stanford, Dr. Phil Beachy, because the fact that FK506 can induce BMPR2 signaling, he found very interesting because he's studying invasive bladder cancer. And in bladder cancer, in the invasive form, the stroma is deficient in BMP signaling. So he said, well, let me take FK506 and see whether I can increase BMP signaling in the stroma and thereby prevent the invasiveness of the cancer. And he did so in his mouse model. So he's now trying to secure more funding to evaluate FK506 for the treatment in bladder cancer. So thank you very much.
We can take one or two questions.
So for those patients who responded to tacrolimus administration, did you take any biological samples, and are you doing any kind of genetics to find out if there's any particular signal or profile that you can use to distinguish those patients and be able to predict sensitivity to tacrolimus? So
they do not have a mutation in BMPR2, but we have just measured, their BMPR2 levels in PBMCs and take this kind of as our way to say, well, they're at least deficient in BMPR2. But we've not done any other genetic studies, whether, there might be more, but that's definitely something we would like to do with a larger cohort also, to just see whether there's a certain type. I mean, generally, I think this BMPR2 pathway is probably important in many forms of the disease, and it might be regulated by a mutation or by an infection, and really targeting this pathway might be helpful for many patients. Yeah.
David.
Yeah, thank you. That was really exciting. I guess I'm curious as I think about how do you find a company that is prepared to sustainably make money out of generating this indication, and just wondering if the enormous cost savings to institutions, insurance, et cetera, wouldn't warrant the use of a licensed drug at a low dose in order to, if you can spare multiple hospitalizations and lung transplantation, you've already earned much more money than you could possibly. So
our approach is now really to try to get funding either from the NIH, or we have like a grant proposal for the Department of Defense, because it seems, that they should be much more interested, and to healthcare providers, like with help of Kevin, to also see whether some insurance companies might want to step up, and fund this.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.